Okay, hello everyone. Thank you for coming today. A special thank you to you, Dr. Elwert, for participating in this. For those that do not know, Dr. Elwert is an assistant professor at the University of Kentucky. He is also the medical director for the stroke rehab unit at Cardinal Hill Rehab Hospital. He's also the resident research coordinator for the University of Kentucky's PM&R residency program. More importantly, he's a mentor, he's a friend, and he's an absolute advocate for AOCPMR in general, as you can tell by his awesome shirt. So, please, if you don't know him, if this is your first time meeting him, congratulations. He's the best. And so we're excited to hear what you have to say.
Well, Clay, thank you. I'm a little embarrassed now. The light may show my getting a little blushful. So, well, listen, guys. First off, welcome. I'm so excited. There are so many things you could be doing on a Wednesday night. For those on the East Coast, it's getting to be late, and so thank you for taking the time to zoom in and to talk about probably one of my favorite papers. And so, with that, let's just go ahead and get started. Let me share my screen first. All right, you guys good? Can you see it? Perfect. If you happen to have the paper, awesome. I've got my copy right here out, ready to go. There's a lot of whole big words in this, but we're going to break it down. And at the end of this, what I want you to be able to do is be able to utilize this knowledge in clinic, because that is the ultimate goal with papers, right? Is that it makes a change in how you practice clinically. And I can say that this paper has done such. So let's go ahead and get started. So at any time you go through a lecture or journal club, some type of speaking engagements, you have to have objectives. And so these are the 3 objectives that after the next about 40 to 45 minutes that I would want you to be able to kind of understand and be able to discuss. Is 1, understand the concept of spasticity in one way that it is scored. Some of you, this may be a completely new concept, and that's A-okay. Some of you, this might be a bore for you because you know everything there is about spasticity, but we have to talk about it so everyone is on the same playing field to discuss this paper. The other thing that I want you to be able to do is be able to identify the different modified Heckmatt grades. And then I want you to be able to outline the importance of these grades and how you can use it in spasticity management, specifically with targeted chemodeinnervation with botulinum toxin. Now, all these objectives, I got to tell you how I'm going to get you there and how I'm going to discuss these objectives and how we're going to accomplish the tasks. And here's how we're going to do it. So first, we're going to talk about the demographics of the paper. So the basic bread and butter, what type of paper is this, etc. Then we're going to talk about spasticity. Then we're going to talk about the Heckmatt scale. And there are 2 different Heckmatts, as you will see. Then we're going to talk about the methods and the results that they found. We're going to kind of get in the weeds just a little bit, but just enough to make sure that we can appreciate the stats. But this is not a lecture on statistics, okay? Sometimes you can get really good papers. You can get so bogged down in it. So we're going to recognize its importance, but then kind of move on to how you can be used clinically and then utilizing the scale. So first off, the study demographics. So this is a prospective observational 2-center study that was recently published just about a year ago. The 2 centers that were involved in this study was the University of Pittsburgh Medical Center, so UPMC, and the Division of Physical Medicine and Rehab at the University of British Columbia. And here was the study objective. So in case when you get into residency, as you have your preceptors during medical school, ask you to read papers, I encourage you to go into the introduction and go to the very bottom, the last paragraph. And it always talks about, in that particular section, the study objective. You've got to figure out, is the study objective, does the study actually meet the study objective? Like, do they actually answer that question? And you can easily find that study objective by the bottom part of the introduction. And so what they did is their study objective was to determine the validity and reliability of a modified Heckmatt scale in patients with spasticity, and to compare that data to a quantitative grayscale analysis to establish concurrent validity. That is a lot of big words, but let's break it down as we go, and we'll see if they accomplish this objective. So, we have kind of a small enough group. I see a couple of cameras on with a couple of head shakes. Do you guys understand spasticity? Have you guys seen spasticity? So kind of get a kind of sort of yes. Okay. So spasticity is just one component of a larger constellation of symptoms in a syndrome called upper motor neuron syndrome. So spasticity occurs when an injury happens that is proximal to the alpha motor neuron. So what is proximal, or what is north of the alpha motor neuron? That's your brain and your spinal cord. So any type of injury that occurs proximal to that alpha motor neuron can lead to the constellation of symptoms in the upper motor neuron syndrome, and spasticity can be a part of that. Doesn't have to be, but it can be. Now the question is what causes it? So, if you take a look at the kind of the overarching accepted, quote unquote, accepted definition, is it is a loss of the descending inhibitory signal from the 1A alpha neuron. So in other words, the circuitry cannot tell the muscle to inhibit itself. And so it is in a constant state of activity. With it being in a constant state of activity, it cannot relax. And that is where you get someone that holds their elbow a little bit flexed, because that biceps and that brachialis is in a continuous activated state. Now, of course, this is the most commonly kind of thought of, but then you read a couple of recent papers. There's a really good paper that was recently published by Dr. Lee and several other authors out in Texas. And I think they kind of describe it the best, is it is a disordered or a disorder of sensory motor control presenting as intermittent or sustained involuntary activation of the muscles. So in other words, that muscle is on hyperdrive, and that is why that muscle doesn't relax, because you've lost that signal. There's that disconnect. Now, with that, there are multiple different scoring systems that can be used. The scoring system that is most commonly used is the modified ASHWORTH score. So the original ASHWORTH score was originally developed in the 60s, and it was a score of 0 to 4 with 0, 1, 2, 3, and 4. Well, then in the 80s, two other individuals, Bohannon and Smith, said, you know what, we're going to modify it a little bit, and we're going to add a 1+. You can't add a 5 or something. It's just we're going to add a 1+. And then it was modified again in 2006 and called the modified ASHWORTH score. And at that point, it took away the 1+, added some key characteristics in the second score. All this to say is that the overwhelming majority use the modified ASHWORTH score, and here is that scoring system. So a grade of 0 is no increase in muscle tone. So that is someone has had a stroke, a brain injury, a spinal cord injury, and they have no tone at all. That is a modified ASHWORTH of 0. You would not say, so if someone has not had an injury to their brain or their spinal cord, you wouldn't say they have a modified ASHWORTH of 0, right? Because there would be no reason for them to have tone. So they have an injury, no tone, that's a 0. Now, when I look at scores, I look at the first one, and then I look at the other end of the spectrum and what's the worst. So that is a modified ASHWORTH of 4, and that is the affected part or the affected joint is rigid in flexion or extension, and it does not move. Okay, so those are both ends of the spectrum. It moves a whole bunch and there is no tone, to it doesn't move at all. And then you have different intricacies with each of these different scoring systems. So let's go through them. So a grade of 1 is you have a little bit of tone that is manifested by a catch and release. So when you're testing it at different speeds, it'll catch on you and then it'll let go. And this is typically done at the very, very end of range of motion. Now, a 1 plus is where you have it is the defining feature is that you do have a catch. It's a slightly increase of tone, but it's a little bit further than the end of range of motion. So you're a little bit past half full range of motion. You get that catch and release, and then you can continue towards the end of range of motion. That's a 1 plus. A 2 and a 3 is where it gets a little, you could have some people, I don't want to say argue about it, but we call this the attending effect. I experienced it as a resident where I went in and I said, man, this patient is a modified ASHWORTH of 3. I did range of motion. I was testing them, and then the attending would go in and say, no, there's a modified ASHWORTH of 2. Well, that's because I ranged them the whole time while I was in the room, right? So there's a little bit of difference there. But the modified ASHWORTH of 2 is you get some pretty marked increase of tone that is throughout most of the range of motion. However, even though it's throughout most of the range of motion, it's easily moved. And then a modified ASHWORTH of 3 is you get a considerable increase in muscle tone, and passive movement is difficult. But the key is that it still moves. That's why it's not a 4, okay? So we should understand, we should all be on the same playing field as spasticity. We kind of know what causes it, what does it do, and how is it graded. That's important to know when you're talking about this paper. Well, then the other part is the Heckmatt. So this is probably something that is unfamiliar to you. This was unfamiliar to me when I started to kind of digest this paper when it first came out. And this was a visual ultrasound scoring system that was created by Heckmatt and Dubowitz in 1987. And it was initially used for Duchenne's muscular dystrophy. And what it is it's a scoring system based on the echo texture of the muscle. So as is referenced in this paper, we know what happens when a muscle is in a constant state of spasticity, or in there is a constant muscle disorder. Is what happens is the body starts to deposit fibrotic tissue and fatty tissue into that muscle. Well, if you remember with ultrasound, if you get something that is really dense, it starts to look white. If you get something that's not dense at all, so like a cyst or some fluid, that is going to be dark. That's going to be dark under ultrasound. And so what do you think? So when you're thinking about it, what is more dense? Is it muscle tissue or is it fibrotic tissue? Well, it's fibrotic tissue that is going to be more dense than muscle tissue. So what is that going to show up on ultrasound? That's going to show up lighter on ultrasound than normal muscle. Okay. So what the original Heckmatt scale is, it was a scale of 1, 2, 3, and 4. So a score of 1 was normal. A score of 2 was there was some increased muscle echo intensity, but your bone echo was still distinct. So what that means is they found they scanned a joint in a particular part. So you could say you looked at the tibialis anterior in comparison to the tibia. In a score of 2 is you might see a little bit of increased whiteness or a little bit of increased echo intensity in that muscle, but you could still clearly see where the tibia is and the tibialis anterior was. A score of 3 was marked increase, and then it started to, that bone echo, so the ability to differentiate bone versus muscle started to get a little reduced. And that's because that muscle is now becoming more and more fibrotic due to some type of pathology. And then a 4 is where that muscle is really fibrotic. It's really, really bright under ultrasound, and you cannot see a real good difference between what is bone and what is muscle. So let's I'm very much of a visual person. So let's look at it from pictures. So this was taken, I think just off of like Google Images. And this is a cross-section of the tibia and the tibialis anterior. So there you can see that is bone, right? Can you guys see my cursor? Okay. So this is bone, and then this is muscle, okay? So, and this is particularly the tibialis anterior. So you can see here in a grade of 1, that looks relatively like normal muscle. You could argue with me, Dr. Nick, what about this right here? I'll give you that. It's a Google image. You could probably clean that up. It's probably a little anisotrophy. It could clean up the image, but this is overall a pretty norm. This would be a grade 1. This is normal, good normal muscle. So then a 2 is where we said it was increased, but you could still clearly delineate where the bone and the muscle is. And you can do that here. So you can still see that there's the tibia, and then you can say, okay, that's muscle, but man, that is a lot more bright than this side. So you can see there's a difference. Well, then let's look at grade 3 and 4. Now on grade 3, it's really starting to get difficult to be able to differentiate what is bone and what is muscle, but you can still do that. You can still do that here. I lose it a little bit right there, and then it comes into the picture. You know that here's your bone shadow. And so you say, okay, well, there's bone and there's muscle, but man, that's getting pretty difficult to see. And then you look at 4 and you really cannot differentiate. You can see that is bone, but if you try to follow that, you have just lost that margin. You can't tell, is this right here? Is it bone? Is it muscle? And that's because of how much fibrotic tissue has been deposited in that tibialis anterior in this particular example. So that is the Heckmatt scale and how it's used in ultrasound, and that is the modified ASHWORTH score. So let's take a look at the study characteristics. So again, what did they want to do? So they wanted to assess the validity of a modified Heckmatt scale in assessing the muscle ecotexture and spasticity. So here was the design. So they performed this between 2018 and 2019. They had 2 residents, PGY 3 and 4, and then 2 attending physicians that rated 100 ultrasound images. The minimum that someone counted was 3 and the maximum was 27. They have a muscle breakdown at the so if you go to page 4 at the bottom of the second column, it talks about all 4 raters, how many that they actually counted, and then it gives you a muscle breakdown, okay? And then there was a total of 50 participants. 45 of those participants had upper and lower limb spasticity of some degree, and then there were 5 healthy references of someone who had not had a upper motor neuron injury, and so they were expected to have just normal muscle, normal healthy reference and normal muscle tissue. What was their inclusion and exclusion criteria? So inclusion criteria, they had to be an adult, so they had to be greater than 18 years of age, and they also had to have an upper motor neuron diagnosis with a modified ASHWORTH of 2 that was managed with botulinum toxin. So let's kind of break that down. So 1 is they had to have an injury proximal to the upper motor or the alpha motor neuron. They had to have what they deemed clinically significant spasticity, so modified ASHWORTH of 2. So that's where you get rigid muscle throughout the most of range of motion, and it's someone that is managed with botulinum toxin injections. The exclusion criteria was if someone had had major trauma or surgery to the affected limb. So let's say that someone had a stroke, and on the right side of their body, they had a spastic hemiparesis, so spasticity and weakness on that right side. But then they also had a really significant humeral fracture because of a fall and had surgery. That particular patient would be eliminated per their exclusion criteria. And then what they did is with these 100 images, they graded them with the use of a modified Heckmatt scale, which we'll talk about the modifications here in a minute. And then what were their outcome measures? So we talked about their objectives. How did they measure stuff to actually obtain their the goal that they sought out? What they looked at is they looked at inter and intra-rater reliability, and they also looked at concurrent validity with quantitative gray scale scores. That's a mouthful. I already know it's like 820. You're probably like, oh gosh, we're talking stats. We'll get through it together. Okay, I promise you that. So let's talk about what they changed with the Heckmatt scale. So we should all be experts on the original Heckmatt scale, which we just went through here. Now, the one thing with the original Heckmatt scale is when you get to 2 and 3, it's increased muscle echo intensity and marked increased muscle echo intensity. Well, listen, so I'm looking right now. I see Tiffany and I see Nick's faces because they're on the side of my screen. Increased muscle echo intensity could mean something different to all three of us, and market increase could be something different to all three of us. And so there was a lot of discrepancy of, okay, well, this is a 2, this is a 3, and the modified Heckmatt scale helped to kind of help eliminate those concerns. And so what they did was they started to add percentages. So what they did was on a grade of 1 on the modified Heckmatt, you had normal echogenicity of the muscle in more than 90% of the muscle that is distinct from bone and echo. So normal for greater than 90%, it was a 1. Then a grade 2 was you had some increased muscle echogenicity in 10 to 50% of tissue, but you could still see the bone echo in areas of normal muscle. So 10 to 50%, you're like, it's probably about 30%-ish. Then, okay, that's a grade 2. A grade 3 is where you had a more marked increase, but they at least give us some guidance and to say it's 50 to 90% of the tissue with still a bone echo, but it is reduced. And then a 4 is greater than 90%. You can't see the bone echo. It's just, you just can't really differentiate between muscle and bone. And so you can think about it, greater than 90 normal tissue, that's a 1, 10 to 50% with still a good bone muscle interfaces 2, 50 to 90 with kind of bone to muscle interface is a 3, and then greater than 90%, you can't see the difference between bone and muscle, that's a 4, okay? Let's take a look at the study, the characteristics of the patients. So the average age was 48, plus or minus about 14 years. There 36% of their participants were female. You see the race breakdown, 78% were Caucasian, 12% Asian, 4% Black, and 6% Hispanic. And then there's their diagnosis. So what is their upper motor neuron lesion? So you have a whole bunch of strokes to begin with. So you've got 11 that were cortical, or 11% that were cortical strokes, 2 subcortical, 13% hemorrhagic. And then you've got a smattering of traumatic brain injury, cerebral palsy, multiple sclerosis, and other. In that other category, that is where you're going to have spinal cord injury, hereditary spastic paraparesis, and other conditions that cause spasticity. The other two, the last 2 lines of this table, I think, are very important. The overall years since diagnosis was 14 years plus or minus 12. So for the overwhelming majority, these are patients that have had chronic spasticity, or they're in the chronic phase of their injury. And most of them had been getting Botox or botulinum toxin for about 5 years. Okay. This is, as I said, I'm a picture person. So this is the image quality, the pictures of what the different grades that they had. And so you can see A represents a grade 1. So over 90% of that, that's a normal muscle. That's, that's a, okay, got it. Yep, let's move on. Then B and C is, so B is grade 2 and C is grade 3. And when you take a look at this muscle, you can say, you know what, there's a little bit of increased echogenicity, or hey, there's more white there that's not supposed to be there. But it's, less than 50%, but it's more than 10%. So it falls into that 2 category. You can still see the bone echo right there. And then when you look here, you can certainly say, you know what, the majority of that, so 50 to 90% is a increased echogenicity, more so than grade 4. So this is grade 4 here, where you can certainly say, you can say, man, that's pretty bright. That is a fibrotic muscle. That's a dense muscle, okay? All right, I want to pause there before we get into the stats. Are we all on the same page? Kind of, sort of, we're all good, we're all digesting it. I want you to, if not, you know, this is, to me, this is very informal. I want this to be a beneficial hour. So however long it goes. So if you don't, if you're not understanding something, please, please, please speak up. This is a Planet Fitness lecture. It's a judgment-free zone. There is no judgment whatsoever, okay? All right, let's get into the stats. So everyone's favorite to talk about at 8:30 on a Wednesday evening. So let's first talk about the reliability. So in other words, when 2 residents were to grade this, was it reliable? When all of the graders were to grade it, was it reliable, or was it all over the board? So remember, we had 4 total graders. We had 2 residents and 2 attendings. So the INTRA-RATER reliability, so resident to resident and attending to attending, or they looked at what's called the ICC. So that is a correlation coefficient, and that particularly looks at continuous quantitative variables. So what I mean by that is what they did was they looked at all 4 raters and they said, okay, was it reliable amongst all 4 raters, rater reliability? And it was a 0.76. So what does that mean? So I have the breakdown. So less than a 0.5 is poor correlation. 0.5 to 0.75 is moderate correlation. 0.75 to 0.9 is good. And then greater than 0.9 is excellent correlation or excellent reliability. So the higher the number, the more reliable that the graders were, that the comparison of grading was best. So when you looked at all 4 graders, it was 0.76. So that is good correlation. And you looked at resident to resident and attending to attending, and those were both 0.77 and 0.76. So if you're not a stats person, what this means is that their inter-rater reliability was good. It was really good. It was reliable. Well, then how about intra-rater reliability? So you give me a picture on Tuesday, I look at a picture on Friday, am I going to grade it the same or am I going to grade it differently? And that intra-rater reliability amongst all 4 graders was 0.81. So again, that falls into that good correlation and good reliability. So in other words, yes, there was good reliability amongst the residents and good reliability from the same resident / same attending. Then let's take a look at kappa. So you might say, okay, now we're looking at another variable. We're looking at correlation, but now you're telling me it's a thing called kappa. You can consider it very similarly. It's just kappa is looking at categorical data. So in other words, again, the higher the kappa value, the better or more reliable, more correlation that there was. And what they found was that there were higher kappa values for grades 1 and 4, which makes sense, right? I want to pause there. Both ends of the spectrum, it makes sense to be able to identify, you know, I can identify a grade 1 because it looks like normal tissue, I can see the bone, etc., versus a grade 4, you can't tell the difference. So those kappa values fall into that really good to really good category. So that means there is a good correlation. And then the grades 2 and 3 still have some moderate agreement. It's not as good as it was in the 1s and 4, even with that percentage that they used for the modified Heckmatt, but it still showed moderate agreement with, yep, you know what, we can identify grade 2s, we can identify grade 3s, okay? Now, so let's look at the other outcome measure that they wanted to look at. So if you want to go in and look at like all the software that they used, et cetera, by all means, please do. But you know, I don't want you guys to fall asleep. So when they looked at this, they looked at a computerized grayscale image. And so what they did was they said, okay, well, let's take a look and see how much gray, white to black ratio this has from the computer standpoint versus the human eye. And what you can see is again, we're talking correlation. So we've got now an R value. You can see that that correlation was 0.829 or a p-value of 0.001. So in other words, wow, that is some statistically significant numbers, but what's exactly it mean? Let's take a look. So this is figure 2 from the from the journal. You have your median Heckmatt scale on your x-axis, and on your y-axis, you have your mean quantitative trace. So in other words, that's the variable they looked at for the quantitative gray scale. And what you look at is you look at what was the modified Heckmatt, or what was the Heckmatt score 3, and where did it fall in the gray-white scale. So again, more white, more gray, more loss of that echo texture is going to be a higher score here on your mean quantitative trace. And you can see there is a nice general uptrend, which is what you would expect. So you would expect a modified Heckmatt grade of 4 to have more gray white or more white than you would than a grade 1. So there was a nice correlation, a statistically significant correlation when you compared the residents and attendings grading the images versus the computer grading and looking at the images based upon its gray-white quantitative grayscale. All right. All right, so let's take a look at the results. We looked at their outcomes. That was 2 slides of a whole bunch of stats. So what did the study show? So the study showed 3 main things when you look at it. So one is that a modified Heckmatt scale can be used to assess changes in muscle echogenicity in a patient with upper and lower limb spasticity. Number 1, right? They kind of sought out to do a new scale. Does it work? Yes, it does. Number 2 is that there is, within this scale, there is moderate to high reliability for both attendings and for residents. And then on top of that, when you compare it to the computer doing it, there was a high degree of validity. So that means that the values that were identified by the resident or attending were valid when you compared them to the computer. Okay. Now, you might say, all right, that's cool. You know, you can identify gray, white. This is what the ultrasound looks like. You can look at the bone echo, but why is this important? I found this meme. I found it the other day when I was putting this together. I had to put this in. I thought this was hilarious. To me, this is a huge deal. So in neuro rehab, this is, you know, when I'm doing both, treating spasticity with botulinum toxin. This is huge for patient outcomes, and it's just pretty daggone cool. So first off, what is this that I have pictured? Someone unmute and tell me, what do you think I have here pictured?
Botulinum targets.
Yeah.
Oh, there we go.
You're exactly right. So these are botulinum targets. So this is your acetylcholine synaptic vesicle. These are all of your snare proteins, so syntaxin, VAMP, and SNAP. And then this is your synaptic cleft. So what happens is you've got the synaptic vesicle. It moves towards the synaptic cleft. All of these guys have a party, they bind, and then they release that acetylcholine into the synaptic cleft. That's how you end up having your muscle contraction. Well, this is how Botox works. So you have all different types of botulinum toxin. You've got Botox, which is A, then you've got B, and you've got all the different brand names. These are the different targets that you essentially, this is what you target with botulinum toxin and how you reduce that spasticity, okay? So let me ask you something. So I'm gonna bring back the pictures. So this is a normal muscle, right? This is what's going on in all of us when we're, you know, contracting a muscle. Do you think that if I inject a muscle, so this is, we're pretending this is a needle, okay? If I take my needle and I inject here, I'm probably gonna get okay results. It's normal for the most part, normal echo texture, it's normal muscle. So I can target my botulinum toxin here. What about here? Do you think I'm going to get as good results here? And the answer is no. And the reason why it's no is, what is all this? This is all fibrotic tissue. And so botulinum toxin does not work on fibrotic tissue. It works on the synaptic cleft and the and our synaptobrevin, SNAP25, etc. And so those aren't there in that fibrotic muscle. And so this is why this is such a huge deal to say, you know what, we're going to use targeted chemodeinnervation with botulinum toxin. And if I'm looking at a muscle and I say, oh man, that's a modified Heckmatt of 4, probably not going to inject that muscle. They're probably not going to get good results. So like, for example, let's use elbow flexion. All right. So a lot of patients after a stroke, so that is predominantly what I see, have elbow flexion spasticity. So if I go and I scan a muscle, so I bring out my ultrasound and I look at the biceps, and the biceps has, it has a little bit of increased echogenicity, but let's call it a modified Heckmatt of 2, for example. Well, then let's say I go a little bit more medial and I look at that brachialis, and that brachialis right where I have the ultrasound is a modified Heckmatt of 4. What I'm going to do is I'm going to scan north and I'm going to scan south of that muscle to see, one, is there a difference in the organization of that fibrotic tissue? And can I get more benefit somewhere else if I inject? Or have I kind of lost the ability, quote unquote, to inject the brachialis, and I need to go to other elbow flexors, so secondary elbow flexors, to get more results and to get better patient results? Does that all make sense?
So question.
Yeah.
What, when you're talking about scanning the rest of that brachialis muscle for other fibrotic changes to see, even though it's a 4 right where you're at, but it could be better elsewhere, what about where the end plate is, where the synaptic junction and the end plate for that muscle specifically is? What if you have a 4 at the end plate? Even if you injected somewhere else in the muscle, would it have any effect if the fibrosis is at the end plate, so there's not much communication to be had in the first place? Does that make sense? It's a really weird question, and it might be misguided. I'm sorry.
No. It is an excellent question, and it's actually a little bit debated in what you look at. So, for example, in kind of what you go by, Nick or Nicholas? Nick. So what Nick is kind of referencing for everyone on the call is, right, as we all know, the muscle has different motor points. And I have the book in my backpack here. There are outlined points in a muscle that are called motor points. So that is the most bang for your buck. So that neuron comes in and it's innervating that muscle, and the most innervation is happening at that spot. So what Nick is kind of asking is, okay, so if you go to that motor point and you see that they've got a Heckmatt of 4, but you scan proximally and maybe you're off the motor point, but you see a Heckmatt of 2, what do you do? Is that kind of what I'm gathering, Nick? Is that kind of the question? Yeah, so I mean, it's excellent. And that's where I argue that in the majority of our chemodeinnervation that we do dual guidance. So what I mean by that is I've got the ultrasound and I'm looking for spastic changes, but then I've also got an EMG needle that is telling me when I am close. So for me, this accomplishes quite a few things. One is I know I'm injecting Botox into a muscle that it will respond to, plus I am injecting the muscle at where it is innervated. So, as you go through your clinical experience, a lot of times what will happen is you go into a muscle and you hear a whole bunch of static. What your attending or what the resident might do is they might advance that needle just a little bit more, and you hear that static get higher and higher and higher. That's because you're getting closer to that motor point. And so then what you can do is you can add that second layer. You can put the ultrasound on and say, hey, look, this is a prime spot. I'm getting a whole bunch of EMG activity. I'm in a good part of the muscle. That is the slam dunk. Let's inject it. Okay. Does that make sense? Does that answer your question, Nick? It's an excellent, excellent question. It's actually something that I kind of debate with my colleagues of why I think we should do more ultrasound guided chemodeinnervation on top of EMG, because we do a whole lot of EMG. So then a very valid question with this is say, okay, Dr. Nick, I understand this concept, this all makes sense, but what does the data actually show? Does it show a difference in if you inject a modified Heckmatt of 4 and a modified Heckmatt of 2? Do patients have different clinical outcomes? And the answer is yes. So they mentioned this paper they mention and reference this paper in this article. And to sum this up is they looked at different Heckmatt scales. They looked at a 2, they looked at a 4, they looked at other different grades, and the patients that had botulinum toxin injected into a muscle part that was modified Heckmatt of 2 had better clinical outcomes than a 3 and a 4 after botulinum toxin. So again, we could go through this paper at a whole nother journal club, but I just wanted to reference this of, yes, what we're saying and what this is based on does demonstrate clinical improvement. So what are the take-home points?
Can I just clarify something? I'm really sorry.
Yeah.
So
no, you're good.
What basically this is saying is that even if you were going back to the example of elbow flexion spasticity, you're scanning the brachialis has a Heckmatt of 4 in the region that you're scanning.
Yes.
Whether you go north or south isn't going to matter, because where you've found is there is a modified Heckmatt of 4. Does that give the muscle a Heckmatt of 4, making it not worth injecting? Okay, thank you.
So that was they kind of just said, okay, they kind of gave it like one grade, like this muscle is the whole gastroc is this score. It wasn't like okay, within this part of the muscle it's a this. And for the most part, if a muscle is a score, it's not like you're going to have patches of difference, right? You could make the argument that at its primary motor point, you might have an increase of fibrotic tissue. But for the most part, if you got a modified Heckmatt of 3 in one part of that muscle and you start scanning, you're probably going to find that it's a 3 throughout.
Right. Okay. Well, and then additionally, too, functionally for that muscle, even if you had a Heckmatt of 4 in one part, I mean, not that physiologically that would happen, but it would probably hinder the muscle to the point where even if you could get benefits of botulinum toxin and the rest of the muscle that could benefit, that's not fibrosed, there's not enough there to make a difference anyway.
Yeah. Now, so yes, that is true, but then also remember what we use. So remember what we use botulinum toxin for. So it is to reduce spasticity with hopeful improvement of pain, etc. But remember is when let's use elbow flexion, for example. If you've got someone that is on that scale of a modified ASHWORTH of a good, healthy 3 to a 4, insurance company is going to say, hey, we're not paying for it. It's contracture. Botox is not, it does not work on contractures. Well, what you can do is, and what it looks like is when you take a look at that muscle, you can have a contracture component, but there might be spasticity within that limited range of motion. So what you could do is you could improve on that spasticity where the contracture hasn't developed yet, maintain the range of motion that they have, and then it might help with their hygiene of their AC fossa, pain with where that is. And so, again, the ultimate goal with this is, yes, you want to get as much range of motion as you can, but sometimes you just may not because the patient comes to you way later in their clinical progress. So it's, okay, what changes can I actually make and what am I trying to do? Okay. So the take-home points are these: is utilizing that Heckmatt scale is a good tool for assessing pathologic muscle changes in a patient's chronic spasticity. So that is one of the things that you've got to identify is when we looked at the patient demographics, these were older injuries and in the chronic phase of their rehabilitation. This was not necessarily in their acute stage. And then, utilizing this knowledge for targeted chemodeinnervation. So, for example, when I'm seeing someone in clinic, I just did a lower leg injection the other day. I put it on my physical exam. I said, looking at the tibialis posterior, it appears to be a modified Heckmatt of blank in this area. Scanning the tibialis anterior, it looks like a modified Heckmatt of this. So then that way you can help again, use that knowledge to help guide your chemodenervation. Okay. So first off, before we get to questions, because I'm going to unshare the screen, here's my contact information. So there's my email. I'm a big Twitter person. I love it. Yeah, it's funny. It's because of AOCPMR I'm a big Twitter person, actually. And then I'm totally cool with my cell phone, guys. If you guys have questions, shoot me a text. If you're like, hey, Dr. Nick, I want to talk about this more, I'll be happy to call you on my way home. I'm pretty much an open lines of communication. Okay. All right. So let me stop sharing and let's get to some questions. What questions do you guys have for me?
And to those of you who don't know Dr. Nick personally, he's 100% serious about that too. So one of the questions I had, this from obviously the unfortunate reality of a lot of our jobs is that we're going to be faced with insurance battles. And so from a fighting for your patient perspective and getting what's best, do you see this as, are insurance companies considering this yet, or are they still basing treatment off of modified ASHWORTH? And if if the insurance company says, no, this patient doesn't meet criteria for Botox, and you say, well, this modified Heckmatt scale it says otherwise, are they taking that into consideration? Is that even a remote thought at this point, or are you using this more just for yourself at this point and your patients and waiting for insurance to catch up?
So I think it's, I do think there's going to be a catch-up period, but to me, it is building an argument for your patient, right? So I'm in the process, as I am a new attending, I am getting patients that are what you would call botulinum toxin naive. So what that means is I've got to assess them, and then I have to make the argument to say, you know what, this is why they need chemodenervation. This is why big insurance company that, I want you to pay for this. And so it is a component that I use for making that argument, but then also to help, honestly, to help have my patients have better outcomes, right? So if I look at that biceps and that biceps is a Heckmatt of 4, well, I'm not going to waste the Botox in that muscle, because I'm then going to go to brachioradialis, brachialis, and I'm going to use other types. I'm going to attack other different muscles than that. So it is all based upon the argument that you make. Is insurance company, they're going to base it more on the actual clinical scoring than an ultrasound score. But I argue that you should include it. Now, I'm going to be very upfront. Am I scanning every single patient that comes in for botulinum toxin? You can't do that, right? That is just not very time efficient. But if I have a patient that has a real significant elbow flexion spasticity, and I'm planning on what I want to inject, yeah, I'll throw an ultrasound on it and say, that biceps looks okay, and the distal 1/3 or proximal 1/3. You know what, that brachialis looks good, and this looks, I want to avoid this. I'll put an ultrasound on and scan it real quick.
And my only experience from knowing what insurance
Joshua,
pays,
no worries, I get it.
knowing
go
what
help
insurance
out in the
pays
kitchen.
in terms of amount of Botox, does it vary with PM&R as well? So, how much will insurance allow us, and how much will they cover in terms of the actual volume of Botox? Because I know that guides a lot of, if I only have X amount and I'm not going to put it in a big muscle, when in reality it's better for 2 or 3 smaller muscles. So how much does PM&R, is it vary by patient? Dr. Nick, did you hear me?
Oh, I did. You cut out, but I got what you were saying. So to answer that question is, you've got to know what first the literature says and how much Botox you can actually use. And so, before you start reaching side effects. And so what that number is 600. So there was a more recent article in the PM&R journal that said 600 is about the max that you can do before you start getting into side effects. So then once you know that number, then it is planning what muscles that you actually want to target. And this is why this is my best friend. So this and me go to clinic, almost every single clinic, and I say, okay, just to remind myself, okay, the blank muscle is, these are the dosing ranges. And I'll say, you know what, someone is Botox naive, they've got real significant tone in their upper and lower extremity. Let's start with 400 units, or let's start with 300 units. As I'm going through separating out, okay, I'm going to delegate 50 here, 50 here, 50 here, 50 here. And then, okay, if that equals up to 400, I'm asking insurance for 400. And so it's that one, you got to know what the max amount is, and then you have to piece together is what is going to be best for the, what is going to be best for the patient and what are the goals. So, yep, this Tex is my best friend. We go to clinic we go to every clinic together.
Awesome, thank you.
Yep.
I have a question, and maybe this research exists and maybe it doesn't yet, but I'm just wondering because mainly this study focused on like the older, like folks who had more chronic problems. And I was wondering if there's been any research in folks who have like more recent injuries and if there's like any difference in efficacy at that point.
So with efficacy in looking at the Heckmatt scale and how it does or does not change, I have yet to be able to find that. I just don't know if I just cannot find it yet. There is literature, and I actually debated talking about this one at this journal club as to talking about the clinical outcomes in the use of early intervention Botox. So early intervention Botox, what this paper discusses is 90 days since their stroke is what has been found to have the best clinical outcomes for management of spasticity. Now, you have to remember that is from the onset of their stroke. So let's say someone has a stroke, they spend 2 weeks over at acute care because they have a couple of complications. Then they come over to acute rehab for 2 to 2.5 weeks. Well, then all of a sudden you're a month down or you're 45 days into that 90-day period. Well, then what happens is neurology doesn't really follow up until 6 to 8 weeks afterwards. This is why I argue I like to follow up with my strokes in about a month once they get discharged, because you're still in that window to be, you know what, this is the window for best clinical outcomes if I need to inject with botulinum toxin, and I can do such, again, with practicing evidence-based medicine. Now, looking at that and correlating it with the modified Heckmatt, I'm still trying to find it. I don't know if it exists. It is probably the Dr. Pacelli that does it, because it is the paper that I kind of screenshot. He does a lot of awesome work when it comes to this stuff. It's an excellent question. What else you guys got for me?
This isn't even necessarily a question, but just a comment. Like, this is just such a fantastic article to speak about just what Tiffany's saying. I think that, hopefully I see it as the future as like a grading scale for the effectiveness of botulinum toxin or anything technically involving muscle fibrosis. And I just think, it's young and, and correct me if I'm wrong, but, you had mentioned earlier in the characteristics of the patients that they chose, they were like 14 years out. Does that change? Does the speed at which muscles fibrose change on, different injuries or, age of the population? And, are those things that we could monitor with this modified Heckmatt scale moving forward?
Yeah, I think it certainly is. And, I think to kind of even add to that is maybe you could have a couple of hallmark muscles that you look at as someone progresses after their spasticity to see if there's an indicator for developing or worsening spasticity. I think that would be really interesting, very interesting to see. And what's interesting is, when this started to come out, to be honest with you, this for me, so my career has kind of taken an interesting kind of process. And, for those that have heard this, you can tune out, that's fine. But I was going to be the sports and spine doc, and that's because got to use the ultrasound, got to use, got to use the ultrasound for injections, yada, yada, yada. Well, then when I fell in love with neuro rehab, I was like, oh man, I kept getting told, well, now you're not going to do as much ultrasound with it because, you don't utilize that much of ultrasound with neuro rehab. And that's so not true. And so I really realized, why do I like, for me, sports medicine and musculoskeletal medicine? And that's the application of anatomy and the use of ultrasound. Well, neuro rehab is like applying anatomy on steroids, because you've got all the peripheral anatomy and the central anatomy, and I'm using the ultrasound. So, it gets me giddy just talking about it, because I love what I do. This is exciting. So why I went to PM&R, and I get to really help patients out this way with skills, a skill set that I developed in residency, and a thing I love to do. So it's some really exciting advances as ultrasound becomes so popular, how we can use it in the neuro rehab field. What other questions we got? I don't have much going on tonight. All I'm going to do is get on the Peloton and bike probably. So, man, I'm here as long as you guys want to talk.
Thank you for taking the time to present this paper. Really fascinating paper.
Of course.
I was wondering, if someone has a Heckman scale of 4 and you wouldn't look to do a botulinum injection, what alternative therapies would you look at?
So it depends. That's a good question. It depends on what their clinical picture looked like, right? So if you're talking about someone that has contracture and they're younger, is there an ability for some type of surgical procedure? Also, again, depending on what their clinical picture looks like, are we talking that we need to do some type of nerve block? So do we need to do phenol neurolysis? Do we need to do some cryo neurotomy, or do we need to do, some ethanol block? So it's going to depend on what you're trying to get. And, there is, some, there's, I definitely think some validity to saying, for elbow flexion, let's go ahead and do a musculocutaneous nerve block, and then you save that botulinum toxin for maybe the hand or the forearm or something like that. So it's this game of, okay, well, if I'm going to do something else here, then I get this Botox that is approved to go here, and then vice versa. So it's really based upon what they look clinically to make that determination. Seeing if there's anything in the chat. Yep, Ronald, I agree. That is, love to see ultrasound being used for this. That's.
Well, yeah, I just wanted to say thank you so much, Dr. Nick. Honestly, this has been one of the absolute better ones. Just a wealth of information. Expect nothing less, but just a genuine thank you for taking the time for doing this. Everyone really appreciates this, and will honestly use this on their clinical rotations, no doubt. But really, a heartfelt thank you for taking the time to do this.
Of course, thank you so much. Did you guys find this good? Was it beneficial? Was it worth the hour?
I
Okay.
was lucky to do when I was shadowing and working with some other PM&R docs. I was lucky to kind of see some botulinum injections happening, and one of them was using the EMG. And so when you were talking about that, I'm like, oh yeah, I know that. I've been there. I've done that. And so to see
Yeah.
ultrasound come into the mix with it too is super exciting. So I'm excited I was actually just thinking, oh, I gotta text him after this. So I'm gonna text him right now and be like, hey, you know what the So thank you. It's cool.
Yeah. Now I'm going to be devil's advocate and kind of say that, this is amazing. This is awesome. There is also the point of you've got to be efficient in clinic, right? So there are quote unquote clinical demands. Does this take a little bit of extra time? It does. But for me, at the end of the day, every decision I make is what is best for the patient. So if it's going to take me a little bit more time to make sure that the patient has better outcomes, then there is no decision. The decision is made up for you. And so you will get some argument to say, oh, don't want to use ultrasound because it takes too much time. Or if you're doing it with a sterile probe or like a cover on a sterile probe, there's more equipment and more supplies that are used. I don't shoot that argument down hastily, but again, I bring to the point of this is what the literature says. This is why I'm doing this, etc. Every decision you make from here on out in regards to your career as a doctor, if it is patient-centered, you will not go wrong. So I'll leave you with that, I guess.
Thank you so much.
Yeah. I'm being honest. Text me if you guys need anything. Shoot me an email. Find me on Twitter. Whatever you guys want to get in touch with me, by all means, just let me know. Okay.
Thank you again, Dr. Nick.
Of course. Thanks, Clay. Thanks, everyone.
Thank you. Appreciate it.